Good afternoon, everyone, and welcome to the Maternal Health Echo series. This training is brought to you by the Center for Substance Use Training and Telementoring CSTAT in collaboration with the Perinatal Psychiatry Access Network, PeriPAN. My name is Andrea Hebler, and I will be facilitating this conversation today. But before we start, a couple of important housekeeping items. This session is being recorded for later distribution, and you will find it in the Be Well Texas YouTube page whenever you want to revisit this recording again. The information that you see on the chat will not appear on the recording, so please continue adding your names, email addresses, and organizations on the chat. This will help us confirm your attendance to this class. We prefer if you keep your cameras on, but regardless of how you join, we're just very happy to see you here supporting this program and learning alongside with us. And today we're having Dr. Emily Humphrey presenting. Welcome, Dr. Humphrey. And right after that, we're going to have 5 minutes approximately for a round of questions. And then Dr. Joyce Subring will be discussing a case. During this part of this session is when we invite all of you to offer your perspectives, your ideas, your views. Please remember that echoes are the space of all teach, all learn. So we definitely want to hear you and count with your participation to make this conversation a lively, fun, and interesting one. So we're going to start with some introductions for the Maternal Health Echo Hub, starting with Dr. Anastasia Reese. Welcome to the session. Dr. Alak, welcome to the session. Do you want to introduce yourself?
Hi everyone. Thank you so much, Andrea, for having me here. But this is great. I'm one of the addiction trained psychiatrists at Texas Tech University Health Sciences Center, also an assistant professor. Work very closely with the trainees, and I'm very thankful to be here.
Thank you. Dr. Subring, do you want to introduce yourself to the group?
Hi, good morning. My name is Joy Subrin. I'm a doctor in behavioral health and a licensed master in social work. And I'm coming to you from Banner UMC in Tucson. So it's 10 a.m. for me. So good morning from Arizona. I'm so glad to be part of the hub and to share in the richness and wealth that you all bring. And so happy to be here. Good morning.
Thank you. Welcome to the session. Maybe this time Dr. Reese can unmute and introduce herself to the group.
Hi, my name is Dr. Ruiz. I'm one of the perinatal psychiatrists, and so I'm super excited to hear about this case today.
Welcome, Dr. Reese. And Emily, welcome. If you can briefly introduce yourself and we can take it away with your presentation.
Hi, yes. I'm Emily Humphrey. I'm a DNP, and I've had 12 years of experience doing both inpatient and outpatient addiction medicine, mostly with pregnant women. And I do have a bit of a cold today, so y'all forgive me as I'm presenting.
It's okay. I think we can start sharing your PowerPoint didactics.
Awesome. So I'll just jump right in for the sake of time. So today we're going to be going over care coordination with midwives, doulas, and lots of other specialty care providers. There are no disclosures for me. And learning objectives. So first, I'm just going to describe the various roles that are often involved in the care of a pregnant patient. There's no way I can cover all of the roles, but I'm going to try to highlight some of the top ones and some of the key differences that often get confused. Then I'm going to create kind of a tailored care plan for patients that really empowers them and helps include all of these different care partners, because that can be rather complicated. I also want to give you all some very practical tips that you can start doing like this afternoon in clinic, no matter what your role is, to help decrease stress and anxiety on the mother when she relates to her care team. And then also for us to identify our professional responsibility to take the extra step to coordinate care with each various team member, because it can be a little cumbersome. So overarching thought, I'm going to start with a quote and end with a quote today. So I love this quote from Henry Ford, and I think it really is a good thought to keep in our little brains as we go through this presentation. And that is, he said, if there is anyone's secret for success, it lies in the ability to get the other person's point of view and see things from that person's angle as well as from your own. And I think that's so important for us, for these mamas, to try to understand what they're experiencing and where they're coming from, and maybe where their care team's coming from and support partners. If we can kind of get in their heads a little bit, we are going to be much more successful in supporting them. So again, overarching thought, let's get in that mama's head. So I tried to think of all the different things a brand new mom is hearing, and she is hearing a lot. So here are some, and I could have made this slide huge, but I didn't. So let's just kind of go around the wheel. So she might hear regarding labor and delivery, go all natural. That's the way it's meant to be. And then she goes and talks to her mom, who says, no, get that epidural. And then she talks to someone else that says, you have to breastfeed, breast is best. And then she talks to a friend that says, no, fed is best. She hears sleep when the baby sleeps. But then someone else says, oh, you have to feed on demand, so you need to be up all the time. She might hear from someone else, stay home and cocoon with that baby for 30 days. And then, she reads in a book that it's really important for her to get out of the house really quickly to help with her depression and to start in a routine. She might hear, this is one I hear a lot, is no medications are safe in pregnancy. Don't take any. But then she goes to her doctor's office and they prescribe her a medication. And so you've got to take care of yourself first. So this mom is hearing all of these mixed messages. She's wanting to do the best she can. She's so confused, right? That is a lot. And then she comes into your clinic, whether you are a medical provider or social worker or counselor, lactation, right? Just know she's coming in and she's got a lot already on her shoulders. I know that when I was in school, they talked about birth plans, right? And some of my preceptors, I won't name names, but would kind of roll their eyes when a mom would come in with this detailed birth plan. They'd be like, oh, like, it's never going to go that way, right? And I think I probably picked up on that from these preceptors. And then the longer I was in practice, I thought, no, this is a beautiful thing. This is a mom that's planning ahead, that's looking at her options and doing all of these ahead of time. And no, it might not go as planned, but let's embrace this. And that's such a beautiful thing that she is trying to accomplish. And so to talk through this with her, because this can all be very overwhelming. And so one thing I always recommend is ask mom, just be like, hey, what books are you reading? Where are you getting all your information from? Who is important to you? Who's important in your circle? Who's going to be supporting you? And kind of like getting in her head and figuring out where she's coming from first, before you start to then give your opinion on how she should do things and be another person speaking into all the confusion. So why does support matter? I think, if I'm being honest, there's been times that I'm like, oh man, I just wish they could just listen to what I have to say and stop listening to everybody else, right? But that's not realistic, and that's not good either. It is so important for moms to have lots of support. So in this multivariable analysis, it showed that controlling for demographics and pregnancy-related factors and prenatal anxiety and depression, women who reported consistent support had a prevalence of elevated perinatal mood and anxiety disorders, half of those who did not. That's a big deal. So having that support cut those symptoms in half. And so that's one of the reasons support does matter, even if it does make things a little more complicated at times. Continuing on with this idea of why support matters. So there was a pretty big study. There was a cohort of 3,000 women, and this study examined whether perceived social support during early pregnancy, so way at the beginning, affected depression 6 weeks postpartum. And there were significant associations between low perceived social support early on and then postpartum depression later. So let's go into some of those common care team members. Like I said, there's a lot, so we can't go over all of them, but these are some of the common ones you might hear about. So midwives, OBGYN, maternal fetal medicine specialist, childbirth educators, lactation consultants, social workers, doulas, and then I'm including family members and friends. Maybe they're unofficial, but they are definitely care team members in this, and we need to include them. So on the next slide, if we keep going, I'm going to define these out a little bit more because these roles are different and sometimes we get them confused, and it's helpful to know the differences. So in the medical support column, these are nurse midwives, OBGYNs, and maternal fetal medicine specialist. And we're going to kind of talk about these a little bit more in a second. And then the right side, I'm putting as non-medical support. And I recognize this isn't as clean cut always, but for the sake of this. So non-medical support are doulas, childbirth educators, lactation consultants, social workers, family members, and friends. And so think of the right side as these are people that provide emotional, physical, and informational support during pregnancy, labor, and postpartum. Both of these groups are providing education, right? But a lot of them have different backgrounds. And so the education they might be providing this mama is going to be different. One other support person I thought of later was a chiropractor. I know a lot of women see chiropractors during pregnancy, and they're getting information from them as well. And so knowing how these roles are different can be helpful. So let's go to the next slide. I wanted to parse out these because this is where I think it gets really confusing at times. Doulas often get lumped over with nurse midwives and OBGYNs, but they should be separated. And so the nurse midwife or OBGYN is a licensed healthcare provider who specializes in pregnancy, childbirth, postpartum care, and general women's health. They can deliver babies, they can prescribe meds, perform exams, and do all of those things. The doula, on the other hand, doula is not going to prescribe meds. They are not going to help the baby be born in that way, but they are there to offer comfort measures, advocacy, and guidance. They support births in all different settings. And doulas are really important. And doulas have been around a long time. We could have a whole presentation on doulas, which we don't have time for today. But they can do a lot. And I know for us, we had a doula with my first. We have 3, and we had no family in town, and she was our only support. And I mean, there were moments where she was reminding my husband, hey, make sure you're eating. And she took our dog on the walk and things like that. Like those are really needed support things for us when we had nobody else there to help us. And so doulas can be crucial part of the support team, but they're not providing medical care per se. Okay, go to the next one. So let's talk about doulas specifically a little bit more. Doulas, it have been shown that the emotional and physical support provided by them shortens labor and decreases the need for C-sections, forceps, and vacuums, oxytocin, and analgesia. Doula-supported mothers also rate childbirth as less difficult and painful. Unfortunately, it kind of made me sad. The same study found that labor support by fathers didn't have the same benefits. So those poor daddies are trying to help, but doulas are specifically trained, and it makes a difference. Early benefits from doulas being involved show reductions in the state of anxiety scores, positive feelings about the birth experience, and increased rates of breastfeeding. These are all great things and things we all want. Later postpartum benefits includes decreased symptoms of depression, improved self-esteem, breastfeeding, and increased sensitivity of the mother to her child's needs. And all these little quotes that I'm taking, these were from 12 individual randomized trials that compared obstetrical and postpartum outcomes between doula-supported women and women who did not receive doula support during childbirth. So here are some hot topics. We could fill this slide up also, right? But these are some things that are going to come up. So breastfeeding, pain control, immunizations, sleeping arrangements, and medications during pregnancy. Those are our big ones. And so again, I mentioned this previously, but ask mom what her goals are. Ask her what her support system is saying, Another one that comes up often is circumcision. I've heard some differing views in family units between that, and that can cause a lot of strife. And so talking about these topics and, if she brings up, I don't know, let's just say, for example, medications during pregnancy. Maybe we are wanting to prescribe a medicine for her depression and she doesn't want to do that. Asking her why. And maybe she says, my mother-in-law told me not to. Saying, okay, it sounds like your mother-in-law really cares about the health of your baby, and that is so wonderful. But there's a lot of studies that show that this is safe, and kind of talking through that with her and empowering her. Give her the tools so that she can go back to those care team members and say, I so appreciate your input and that you care so much about me and my baby. But I've talked to so and so, and this is, what I've found, and this is kind of what the evidence shows. And giving her that information to help her make a decision that's right for her and baby and empower her to do that. Because pregnancy is such a great time of practice for parenting, right? Because that's going to happen the rest of our life as parents, since we are always getting different messages and different advice. And that's one of the difficult things as a parent, is to try to figure out how to navigate that. So starting to practice these hot topics early with mom, finding out what she wants, giving her the evidence-based information, and then letting her make those decisions with her care team is really, really important. So how can we work together? Overall, keep mom at the center. Parenting should be a team effort. It should be the whole life of this little one. So start practicing that now. Give her choices. And so I like to lay it out there and say, okay, again, going back to this medication example, I say, that is one school of thought, and that is great. Here's another one, giving her choices, laying out the information, give her control to make those choices. Give her information that's clear and not overwhelming, and help her plan and be prepared. That is going to give her lots of different perspectives, and also invite others in and be on the same team. So one of the most helpful things I've done is to invite these various people into the room, which can be stressful and can be really unpredictable. I will say that. But if moms tell me, my partner really doesn't want to do this and this and this, or my partner doesn't know that I'm using opioids and on Suboxone. They don't know that. I say, well, let's go ahead and talk about this now. It's easier to talk about it now than later. And so I have had many visits where I say, why don't you bring your partner in, or whoever this person is, or maybe it's the doula or whoever. And I say, let's talk about it as a group. Would it be easier? And usually the mom is like, oh yes, it would be so much easier if someone else was here and could talk about this. And so I will say almost all but one of those times it has gone really well. I've had one that did not go as well, but all the other times it did go really well. And I was able to kind of be a middleman and say, mostly it is around Suboxone and pregnancy. That's usually when it comes up. And, to talk about the safety of it and pregnancy and breastfeeding and answer questions. And usually the partner, feels a lot of relief and feels validated and feels a part of the team as well. And like they're important and that they were invited into that conversation. And so that's empowering to mom, but it's empowering to these support people as well. So this is a very practical way to empower your mamas. And I know this is a lot on here. You can copy this verbatim if you want later. This is an example of what I do in clinic. And this is for Suboxone or buprenorphine for my patients that have opioid use disorder. So one thing I was finding was we would get these mamas stable. They would be doing so well. And then they would go to the hospital and have their baby. And someone that just didn't know would tell them, oh, it is not safe for you to take that while you're breastfeeding. I heard that a lot. And so this might be a well-meaning lactation consultant or well-meaning whoever, right? A new nurse that doesn't know. And then the mom all of a sudden is like, wait, it's not safe. I'm not sure, and doesn't know what to do. And then they stop taking it. And then I had a few of them that would go into withdrawals when they're postpartum and just had this baby. It's the worst time to do that, right? And then they'd come into my clinic, a week after a delivery, and they'd be off their meds. They would be sick. It was terrible for everyone. And so I started doing these educational things at the hospital to try to educate everyone like, hey, Suboxone is safe during pregnancy. It's safe for breastfeeding. And that would go well for about 6 months. And then there was turnover and new residents. And It was like I was chasing my tail. And so I started making this letter for all my mamas, and we would talk through it together. And the letter explains how buprenorphine can be used for pain control, how it is safe during breastfeeding. It didn't come through on this slide, but I have the references from ACOG and SAMHSA on here. And me and the mom talk about this, and I say, hey, keep this in your go bag. And when you're at the hospital, if someone comes in and says, oh, you shouldn't be taking that medicine during pregnancy, you whip that out and you say, actually, I've talked to my prescriber about this, and this is what they say. And this is, what ACOG and SAMHSA says. Do you know how empowered your mama feels to suddenly have that information? And usually the care team member's like, oh, okay, she knows what she's talking about, right? And so this, like I said, is for buprenorphine, but it could be applied to a lot of different things that your mom's experiencing to try to empower her to have the information to make these decisions. So again, start these conversations early. Pregnancy, 9 months is a blessing and a curse. I know I felt like my pregnancies would never end at times, but there's also this amazing, you have 9 months to figure a lot of things out, right? And to have a lot of these conversations. And so starting these conversations early, about postpartum depression, anxiety, and maybe they're doing really good right now, but say, you've got a history of depression. Sometimes postpartum depression can happen. Let's talk through that. Talk about breastfeeding. Hey, what are your thoughts on this? What did your mom do? What are their support groups? But I think it's really important to talk about those challenging topics. So CPS involvement is something I talk to all my moms that have substance use disorders about. I always tell them to plan on CPS coming in. I say, whether or not it's needed. I find that CPS has been called on my patients a few times because they have Suboxone in their urine, or because somebody sees in their chart they have a history of opioid use disorder and they call, or maybe baby does have NAS and it's from methadone or Suboxone, right? And so I always tell mom, and don't be angry about this. It is a wonderful thing that there are other people that are concerned about the welfare of your child. We want that. So if this happens, you're ready for it. When CPS walks in the door, of your hospital room, you say, yes, I am on this med. Here's a list of it. Here is my prescriber's phone number. I have them sign ROIs. I tell them, sign an ROI, get all that so they can call me and I will validate this. And that has happened so many times since I started talking to moms about this. And almost always when it is something pretty clear cut, CPS will not even open a full case and it will be closed before they leave the hospital. And so again, if mom isn't prepared for that and she's trying to breastfeed this baby for the first time and she's sleep deprived and CPS walks in, that is an insanely anxiety provoking situation, right? But if you've already had the conversation and have a plan in place, mom feels like she's got this, right? And that is empowering. Other challenging topics to think about is like intimate partner violence. I've had multiple moms whose partners are in jail and it was due to violence against the mom. And I'm like, so what's going to happen when your partner is released? And we need to talk through these things. And so these are uncomfortable conversations, but it's so much easier to have these early on and in small doses because they're having to come in frequently anyways. And in the long run, it's going to make your mom feel much, much more in control. And then you can also address individualized concerns, trauma, grief, past experiences, and things like that. So how do we do this? I think a lot of this is very overwhelming for us, no matter what your role is. So for me as a nurse practitioner, I eventually had to make a checklist and I put this in, we use Epic. And so there's a place I can put this in their problem list. And this is roughly what my checklist looks like. I'm not going to talk about all of this at the first visit, right? But I if I have a day where I have a little bit more time, I'm like, oh, we still need to talk about, support during labor and delivery and thoughts on immunizations. And then I know the next time we need to talk about breastfeeding and pain control during labor. And I kind of have these different things. So I have 9 months to go over it. And each time they come in, I kind of address one or two, maybe as time allows. It's not as overwhelming for mom and it's not as overwhelming for me. And really, the time invested in this yields a lasting impact. Your mom is going to be so grateful that you've had these conversations and that she is well prepared and that you are also really respecting those other people that are part of her care team and validating them because they're important to her or she wouldn't have them in her circle. So we do have an ethical responsibility to bring these people in and to go over these things. Some of these checklists, it might vary based on your patients. You might work different things in that you wouldn't for somebody else, but I have found this to be very practical and helpful. And so the last one, this is a quote that I live by. This is from an old woman in her 90s. She told me this years ago, and as a mom, I use this. Um, it's be well prepared and flexible. And I think that's really good for these moms is we can be as prepared as possible and things aren't going to go the right way, right? But trying to be prepared, trying to have these conversations, trying to bring different care team members in and get their opinions and involvement is important. And then we roll with it, right? As things change, we accommodate. And that is it. So I have a few minutes for some questions.
Well, Dr. Humphrey, this has been great, valuable information. Thank you for sharing all this with us. I'd like to open the floor now for your questions and comments. I see here that Joy, do you want to mute and say a little bit more about that, about the pre-written letter?
Oh, sure. Yeah, I loved the presentation, Dr. Humphrey, and I thought that pre-written letter was really empowering. We do something similar on a business card that just says, wherever you arrive, we hope you deliver with us. But let's just say you're traveling or you're on the other side of town and you arrive somewhere, hold this card up, and let them know I'm in treatment. Here's my providers. Like there's no searching because when you're stressed, you could become very panicked. The words don't flow. So I love that idea. I also wrote down, take the time, it will yield a lasting impact. I thought that was just beautiful. So, and I also like the distinguishing, this was your whole presentation, but like the care teams and how we have to work together. And that also takes into consideration that the patient may have a certain point of view or perspective of what social workers do or what this doula is going to. So just saying like we're a whole team. You can lean on us where you feel comfortable because there might be, some preconceived bias or thoughts about different team members. So anyway, I saw a lot of smiles in the crowd. I just love the unity of this team, and maybe this is new or something you're practicing or want to improve or add to in your own teams.
Others in the group questions?
Oh, I also talked about nutritionists. I said there's sometimes nutritionists on our teams. So, because gosh, food and mood and food and choices and food and sleep and all the things that either add to our coping skills or make them harder to access has a lot to do with food also. So that's even like WIC. I love WIC. Not everyone has a dietitian in their network. So anyway.
I love the positive approach on telling the mom, hey, it's a great thing that everybody's concerned about your baby. They're just doing it, it's well intended. They just want to protect the baby. That's a good thing. I never thought about that, especially when it comes to CPS, which we know it can feel so invasive and bad for the mother, as we all know.
Well, and I think a lot of times moms suddenly feel very defensive, as any mom would, right? But when you go into it as they're trying to protect my child, like I am, and look at them as a team member, it helps them relax and be a little bit more open. And I find that it facilitates that a lot better. The whole attitude.
Yeah. And the earlier the better. I would rather have that open conversation at 20 weeks or something than it to all come crashing down, on delivery day. I mean, I talk a lot about, we all do, about maternal mental health. And I think having all the cards on the table with the right players, inviting dad in. I loved how you talked about, if he doesn't know, if the partner doesn't know, how eventually it will surface. And that has to do with my case. So thanks for getting my wheels started. But, what's uncomfortable for them, we want to lay it on the table. How can we make it lighter So,
Absolutely.
so many good points. Anybody else? I feel like it's just me. I'm going to mute myself.
You say still over 5. Dr. Humphrey, this was great. I just had something to add to this. I think one thing that I found was really helpful was actually engaging the partner. A lot of times, individuals or pregnant females are actually not wanting for the partners to be engaged and they're just worried about what the consequences would be. So I think that's really helpful to hear that and how you navigate the process. And I also think like sometimes I wish the laws have really gotten relaxed a whole lot, so not to complain, but I also wish there was more some telemedicine and things like that, which we can eventually develop around methadone, because a lot of patients actually feel like the pregnant ones that methadone does better for them versus Suboxone. I mean, I personally think Suboxone is just easier for them. They don't have to come in as often, but I really wish we had some more help around methadone in terms of like telemedicine and things like that, like we have for Suboxone, which probably is not as much possible, but I think still that would be something that might work out in future.
Thank you, Dr. Alak, for that feedback. That was relevant, definitely. And I think Lisa Dillard has a question.
Yes, thank you. My question is for Dr. Humphrey or any of the colleagues who resonated with that team approach to preparing for the front end of the birth encounter. But my question is on the back end. It's time to go home for the dyad. What does the discharge care planning and the team input look like in best practice? Can you share on the back end a little bit?
Yeah, I mean, I don't know if this is your question exactly, but I know different care team members have different timelines typically on the back end. And sometimes doulas will stay involved for about 6 weeks postpartum, which can be very helpful. And they will go do home visits and help with all of that. And then for like the midwives and OBGYN, they're typically doing a 1 week follow-up in 6 weeks. So not as many touch points as a doula typically would. And then again, finding out who those other family and friend caregivers are. Is mom going to come stay with you for a couple of weeks and things like that? We at our clinic, we were finding that we felt, well, we had one patient overdose at 2 weeks postpartum. And so that changed a lot of the way we did things after that. And so after that, we started reaching out to our moms 48 hours after and calling them and having their counselor reach out to them. And so I think it varies based on the care team members, but for us, we would do a phone call pretty quick once we saw they were discharged from the hospital to check in and see how things went. And that came from their counselor.
That's helpful, Dr. Humphrey. I also wanted to add actually connecting with the OBGYN, because we actually have two patients who are currently pregnant in our program, at the opiate treatment program. And I feel like connecting with your OBGYN is very helpful. Not just, hey, we're here, but also like sometimes personally reaching out to them, letting them know like we are supporting our patients and the CPS and everything. I think that's really, really helpful as well. And I think when they're being discharged, typically what we've experienced in the past with the two patients we've had, and now we currently have two as well, the OBGYN team would actually reach out to us back. Someone from the team would reach out to make sure the transition is smoother and easier. So I think that could be a more of a holistic approach with everyone being a part of the picture.
And also before, I'd like to, I don't know if Alejandra would like to unmute. You have a question on the chat regarding the role of the dad. Do you want to see a little bit more about that? I can read the question. It says, what are your thoughts on including older kids at home, 15, 20 years old, in the conversation, especially if the partner or the other support person is not possible? This might be a question for mental health providers too. Would you like to speak to that, Dr. Humphrey?
Yeah, I think it totally depends on the kid, right? And usually the mom's going to know that better than anyone. There are some insanely mature 15-year-olds and some very immature 15-year-olds. And so I think it totally depends on the situation. But if mom is coming in and saying, "Hey, I've got a 17-year-old daughter at home, she's going to be a very much a part of this." Yes, bring her in, have her come into a visit, see what questions she has, open that conversation up, do it in an age appropriate way, right? And I think follow mom's lead on that and see where she directs. But if this is someone that mom is indicating is important, I think we respect that and we try to bring them in.
Thank you. And I think in the interest of time, we're going to be moving to the case. Dr. Subrin, if you can take over. And I sense that there are strong correlations between the case and the didactic, so we should be able to connect the two. So whenever you're ready, I think we can start sharing the case presentation.
Sure.
The case.
Yes. So, and I would agree. And Dr. Humphrey and I did not work in collaboration, and our cases really do overlap. Such is the reason, 30 or 50 of us are here today. Our cases have so much overlap, and that's why I just appreciate this learning community where everyone can ask questions and share, because we want to do the best by our patients, and what's worked in your community could very much work in mine. So can everyone see this purple and white case?
Yes, we see it.
Perfect. I'm sharing screen. So just to review, I am Joy Subrin. I have been an OBGYN home-based, so I'm co-located with an OBGYN clinic, social worker, and a doctor in behavioral health for most of my professional career. Prior to that, I worked in a domestic violence shelter, a crisis response center. So I really appreciate the last note about communicating with the OBGYN, because that is such a huge goal, and our other partners. So I am here today to share a case that I have. So your input is so very valuable so that we can help this patient during her pregnancy. So I will move pretty slowly through the question answers here, the question answer form. So my patient is 24, Caucasian female, heterosexual, no known cultural considerations. This is her first pregnancy, and she has polysubstance use. Her support includes her mother, her grandmother, and the boyfriend, who is the father of the unborn baby, although he does not know about her current substance use, and some of that being methamphetamines and fentanyl. So my question is, what are some, thus far, let me keep going. Thus far, she has some mental health symptoms that are not diagnosed, but depression, she has some symptoms. She does not have suicidal ideation. So my note here is that it's undiagnosed. We don't know of any historical traumas. She is utilizing methamphetamine, started at age 14. Just want to point that out. She's 24 now, so that's 10 years. Currently using methamphetamine, and she's transitioned to a patch for smoking cessation. She's denied alcohol use. No known history of cannabis, MDMA. So current use of fentanyl, she started that at 19, so 5 years of methamphetamine, and now 19 to 24, the combination of fentanyl and methamphetamines. No known other drugs. Primary diagnosis, opioid dependence, severe. Methamphetamine use, severe. We don't have a working diagnosis or a secondary diagnosis. So behavioral health treatment in the past, she enrolled but did not participate in outpatient counseling. In the present, she was offered but not participating in outpatient counseling. Pharmacological treatment in the past, buprenorphine and naloxone. It was all prior to pregnancy. And that was done through, I'll get there, but through residential treatment program. And she presently has access to naloxone and buprenorphine, but I just noted here it's inconsistent dosing. And I also believe that, I don't believe, she has told me that she sometimes uses her own prescription and sometimes uses a friend's. So it's just inconsistent. So prior to pregnancy, she participated in an inpatient treatment, residential treatment, and we offered that again during pregnancy. So she's about 30 weeks now. So she started care very early, and we offered, re-enrollment in residential treatment, but it was not successful, not accepted. She's had some mutual aid support groups, but I just want to highlight it was when she was at residential treatment. She was offered this again and declined. She was also offered helplines, like we have something called Hope Incorporated. We have like the SAMHSA helpline. So those are things we tried to kind of connect her in her hand for her own time. So risk reduction services we have offered. Immediate inpatient MAT induction, that would be like at our local hospital where she would eventually deliver. We have offered outpatient referrals, so she could go to the clinic for induction and get support and get medication. Residential placement again, and the mental health hotlines for emotional support and sobriety support, like I was mentioning, the SAMHSA hotline or the Hope Incorporated. She has, let's see, she has heartburn. She's on a nicotine patch for smoking cessation, and she's using her prenatal care vitamin. There were no known historical surgical histories that I knew of. So this is a 24-year-old who's about 30 weeks pregnant. I have offered not only myself, but as Dr. Humphrey mentioned, our team, our addiction medicine specialists, our fellows, our MFM team. Sorry if I'm scrolling kind of fast, if that's making anyone feel dizzy. Our inpatient was offered and declined. I even removed myself, thinking like maybe this person has a point of view on social work, like I was mentioning. I said, let me just make a care package, get it delivered to her from her medical provider. I'd really trying to think of any angle why the motivation to change is not happening. So I would love for her to gain stability so we could work on goals. There's just, she's now in the last 2 visits to the OB clinic has refused respectfully to meet with me altogether. So I would love some input from the crowd to make some positive impact on our patient and her unborn baby. Maybe this looks familiar for some of you folks. You can use an emoji if it's familiar, or use your voices, your mics if you have some ideas or some questions, anything I left out.
Absolutely. So we're opening the floor for questions, comments. Oh, Stephanie, do you want to mute yourself and ask that question? It's a good one. Stephanie Keeler.
Sure, yeah. So, is CPS currently involved?
Hi, Stephanie. They are not currently involved. I have reason to believe that the unborn concern has been completed, but at least in Arizona, sometimes it's documented as an unborn concern, and they don't start intervention until there's a child in the home. So their involvement is not yet. Are you maybe suggesting that more calls be made for possible intervention earlier?
Well, let me just tell you what it looks like here. So we have a women and children's inpatient program, but we also partner with Parkland Hospital. So when they have women who go in that are pregnant, we send somebody if they say that they're interested in treatment or resources. And this usually happens when, like, usually CPS is called. So they have the motivation to engage with us.
Okay.
So, yeah. But we have kind of like a kind of like a like a warm handoff from the hospital to us, like knowing that CPS is involved, and then they usually complete treatment. They do their prenatal care and all of that stuff. So I was just wondering because sometimes that is the motivator, especially if they don't have any other children and they've not had that experience yet. Sometimes, um, I mean, that's awful to say, but sometimes that is the reality, and it's hard to face the reality that that could happen until it happens. So that's why I was asking.
Yeah. No, I think that that's a really good angle, to come off as an I want to inform you of this, right? I want you to know, like I've said earlier, that cards are all on the table. Um, yeah, at this point, they are not yet involved, but maybe the sooner the better, just to help initiate some change to partner with DCS. So sorry, CPS is the term
Hmm.
in Texas. So,
Yeah.
oh, no, yeah, I
And
appreciate
then the
that.
second part of my question was, has she engaged with a recovery coach or a peer specialist at all?
Prior to pregnancy, she had, and those are all great opportunities for support and change and just fear, just to have partnership and not being so afraid. I think she's really afraid to walk in the doors for the first time. And so the answer is no. But I would love to make that happen. I've offered her peer recovery support specialists, home visiting, and I know I said, maybe I shared this, that she's not homeless as in she doesn't have a home, but she moves from house to house. So she lives with
Mm.
grandma sometimes, mom sometimes, boyfriend sometimes, maybe friends sometimes. Um, so this would be a person that, could travel with her and be a partner in her recovery.
Right. And even just, because before I'm an RFCS as well. And so I completed our Women and Children's program. And so I understand the big fear. And sometimes only somebody who has been through that experience herself can really get through to someone when they're just shutting you down. So,
Yeah.
yeah.
Oh, that
Oh, well,
speaks volumes. That speaks volumes. I
my
know.
heart goes out to you, though. Good luck with it.
I know. I know. I just really appreciate that angle. And I could say those words verbatim to her if she allows me to. Like, someone who's been there, um, it's just that bond, that support. Maybe it could just make an inch of difference. There's a lot of questions in the chat.
Yes, we have Lisa and then Kobe. Lisa, would you like to unmute and ask your question, please?
Or I can read it.
Yes, you can read it too.
Lisa, want me to read it?
Yeah, my apologies.
Oh, there you are.
Multitasking on the lunch hour before the next webinar. I know that at the birth, there's always the question of name the father, and then is there any question or indicator for doing the paternity testing? And I just hadn't heard any mention in this case presentation of a safety plan, whether it's the discussion of a safety plan before the baby gets here, or is there an organization in her care network that would formally assist her with the safety plan for the baby? There's just so many unknowns and uncertainties that I'm just thinking that that's almost necessary.
Oh, absolutely, Lisa. If I were to fast forward and no change is happening, I sadly think that this would be an automatic removal because of the child, because she's not living anywhere stable. And you mentioned the word relapse. She's not obtained any level of sobriety. She's still actively in her addiction. So I'm afraid that the safety plan would be that the baby would be placed in a foster care um, residential place. That's my fear. But I'm hoping if I could offer some intervention prior to that, that maybe we can empower grandma and mom to be the placement, and that mom could get the stability that she needs to save her life. This is a high risk scenario for mom as well, using medications from other people, her medications, street medications. So the safety plan is would probably be enforced, which is never what we want. And something about paternity testing. I don't think that that would be necessary because I don't think that the father of the baby is denying that. I think he would sign the paternity paperwork. His issue here is that he's just unaware that mom is actively using. So.
And then Kobe, would you like to unmute yourself for a moment? Kobe Ajaji?
It looks like Kobe wrote, I can't unmute, but I can
Oh,
read.
sure. So he's asking any information about her family that could be leveraged since she has support from her mother and grandma.
I thought so with the early part of her pregnancy when I was seeing her pretty regularly. We do see our patients who are high risk much more than like the traditional every 4 to 6 or 5 weeks. We see them like every week, every 2 weeks. So mom was coming, grandma was coming, but I don't know if they're influential in helping her get enrolled in treatment. So maybe they need some encouragement also from like a peer educator or a part of the recovery team. So I think they've watched for 10 years since age 14 to 24. They've been sitting idly by and they need some new skills to help mom make some real change, mom to be make some real change. Is it a planned pregnancy? No, it was not.
Dr. Lubner has a question regarding the medications, right, Dr. Lubner?
Yes, I did. So this is unfortunately all too common scenario. It's almost feel like, oh yeah, I know this patient.
I know. Sadly, yeah.
So I know that a lot of times people who use fentanyl, they also use methamphetamine to prevent fatigue or to deal with the fatigue. In her case, she used methamphetamine to begin with. So it's a little bit different angle. But my question is, so she's using both fentanyl and Suboxone? I mean, isn't that is a little bit of a roller coaster ride?
I think it's a great point. I would love to clarify with her, or at least have the team clarify when she comes in next, because I don't think she knows the risk. I think some of this is coming off the street or from other friends that are, uneducated. I don't think that's the prescription, right? So I think there's some patient education that needs to be delivered to her about the separate types of medication that she's taking and the impact it's going to have on her energy and her ability to make good choices. So yeah, roller coaster ride.
And also the sad thing about this is that this is going to be a recurring scenario. She's 24, she's still got several years of fertility left. So, even if this pregnancy ends with CPS taking the baby away, there's going to be probably another one coming up. So, establishing some kind of connection or treatment or making some kind of progress, even if it doesn't make that much difference now, it could make a difference down the road.
Excellent point. Yeah, these are patients that we're going to see again and again.
Yeah.
So
thank you.
Thank you.
Dr. Riz, would you like to unmute? I see some important points that you're making here in the chat.
Yeah, I was very curious what the fare is that she's avoiding involving her partner. And so, is she afraid the partner's gonna leave her, abandon her, or take the child? The partner's gonna find out, like the PowerPoint, answer her questions. What happens when your partner finds out? What are you afraid of? And would couples therapy help within the underlying relationship dynamics there?
Oh, yes. I'm going to continue to invite myself onto the case and maybe start here because we're getting really close to deliver. I mean, she could deliver anytime. I mean, she's at 30 weeks. We don't want her to, but what exactly are you afraid of? How can we help introduce that conversation? Can we bring him in like Dr. Humphrey? Would it be helpful if he came to the next appointment and we talked about this? I like to use the term, and I think everyone's going to nod, this is a health behavior. This isn't us just talking about the word addiction or use or substance use. This is how we're talking about your health, how we're managing your health. Would you like to invite him in on that conversation? I don't believe there is any risk of him, this person's comment about domestic violence. But yeah, I would just be making my own assumptions if I knew what do you think would be the worst case scenario, what would happen there. So really good point.
I think I would,
Okay,
sorry, go
go
ahead.
ahead. No, go ahead.
I was going to say, I think also acknowledging what mom is doing right. She probably feels like she's doing a lot wrong, but hey, you're coming to your visits even though it's hard, and you are taking buprenorphine sometimes from friends. Why is that? Maybe she is trying to do this on her own, and trying to figure that out. But acknowledging she is coming to the visits and things. Sometimes that's all they're doing, right? But letting them know you
Yeah.
see that, and then I know we're almost at time, so we don't have a lot of time to talk about, but often we in our clinic, we do home inductions with Suboxone from fentanyl. We do a microdosing approach. Um, we took a lot of that from Dr. Sean Cohen. He has a microdosing for fentanyl. And we've had a lot of success. And we found that there was a lot of fear of mom going to the hospital or going away. And they felt more comfortable in their own environment and felt more in control doing it in their own setting. And so I don't know if that's something y'all could consider if she does want to get off the fentanyl and does want to get on the Suboxone, but maybe would feel better doing it in her own environment. And if that's one barrier you could reduce.
Absolutely. I'm so glad you mentioned it. I mean, this is how we grow in our practice, right? Is that one network is doing something and it's working, let's try it. I think it's a really valuable idea that I'll bring up to our care team.
And I think this all have been great questions. There are some good questions and comments on the chat. Just in the interest of time, we're going to go to some brief announcements, and we're trying to make them really short and brief so we can then move to a summary that Dr. Humphrey is going to provide and share with us after this. So please remember, if you want to claim your CMEs for today's class, just text the code CLAIM39652 to the phone number that you see on the screen. Please remember that you have until August 18 at 11:59 to send this code and obtain your CME. And please don't forget to answer your post-session survey. This evaluation is not important just because of your CMEs, but because it provides you with your ideas and your feedback about the value of these sessions for you and for your organizations. So please take the time to answer the post-session survey. And if you have any questions, you can send an email at cme@ttuhsc.edu. Next. And if you have a challenging case, please come and share it here in this space. We make it really easy for you. We'll give you a form and you just will share it with the group, and we will provide expert clinical guidance, supportive peer learning, and you will be exposed to evidence-based resources tailored to your case. If you're interested in sharing a case with us, send us an email at cstat@utesca.edu. Next. And CSTAT offers free technical assistance services for a variety of substance use disorders needs. If you want to complete a TA form with us, just go to our website. There is a TA form there, and someone will respond 2 or 3 days after that. This is a free service for all of you in the community. Next. And CSTAT is excited to announce that we're still accepting applications for the Mood Mentoring Program. This mentoring program is available for prescribers located in the Texas Public Health District Region 8. So we're sharing with you the application. We hope that you take advantage of this incredible opportunity. Again, completely free. And then Jen has some important information about Peripan. Jen, whenever you're ready, you can take it away.
I'm ready. Yes, thank you. Just going to provide a brief overview of the Texas Perinatal Psychiatry Access Network, known as PeriPAN. We are designed for clinicians who see pregnant and postpartum women. PeriPAN was created to address the maternal mental health crisis. Mental health conditions are the most common complications of pregnancy and childbirth, affecting 1 in 5 perinatal women and ranking among the leading cause of pregnancy-related deaths. A lack of access to care and provider shortages further compound this problem. And PeriPan has 4 major components, as you can see on this slide. We do provide clinical guidance to help with a single patient case or enhance mental health care in your practice as a whole. And you can do next slide. PeriPan is anchored by 12 regional medical schools and health-related institutions across Texas. As you can see on this map, signing up is easy and you'll reach a mental health expert by phone and can consult with a reproductive psychiatrist within 30 minutes or at a callback time that you choose. Anyone in your office can call or text to start a consult or request, but each region does have their own unique texting number, which will be provided at sign up, and just call the number on the screen to enroll. And then on the next slide, we should just have our upcoming PeriPan webinar series, which are held on the third Tuesday of each month. These sessions complement these Echo series, offering a deeper insights into perinatal mental health. On the screen, you do see the list of upcoming topics and dates, so be sure to register and stay informed. Connect with our experts and expand your knowledge. We look forward to seeing you there. And then on my last slide, we should have the list of topics and dates for upcoming lunchtime maternal mental health echoes, which are held on the first Tuesday of this month. We do invite you to join us in the future sessions to continue learning about these important topics, engage in meaningful discussions that support perinatal mental health. And Andrea, I'll pass back to you. Thanks.
Thank you. Dr. Humphrey, would you like to give us very short summary
Yes.
suggestions for the case?
Short
Thank you.
summary. Whoever is important to mama should be important to you, so bring them into the conversation. Circle around that mama. She's getting a lot of conflicting information, so empower her any practical ways you can, even if it's just by giving her a letter, and bringing other people into the room, whether it's her partner or other family members, to help aid her with those difficult conversations. Having the hard conversations early is going to be a worthy investment in the end.
Thank you to all of you once again, and we'll see you next month. This has been a great conversation, and please remember we're sharing with all of you this material after the class. Have a great rest of your day. Thank you.